Yeah. Good morning. Welcome to Grand Rounds. Again, if you were thinking of coming in person, we do have some seats available. If you're online, welcome to Grand Rounds. It's a pleasure today to introduce Dr. Reynolds. But before I do, I wanted to acknowledge that we're on the unceded land of the Coast Salish peoples, and we're grateful for for them and for us being here. Today's Grand Round is Dr. Reynolds will be talking about a rheumatology topic, and one that she's trained, has more training in than many of the rheumatologists, and that's in lupus. And today we're going to hear about new therapeutics in lupus. Dr. Reynolds.
Thanks, Larry. All right. Hi, everybody. I think hopefully online folks as well. I don't know that I can actually see the chat, but I left room at the end for questions. So hopefully we can get back to those if anyone has questions going through. I actually designed it to be interactive so you could answer questions, but I don't think I can see if anyone posts those in the chat either. So answer honestly when you see the questions on the board, and we'll go through them. A few disclosures. I have been on a speaker or an ad board for GSK, AbbVie, AstraZeneca, and Sandoz, basically anyone who makes a medication for lupus. But I'm going to try and use generic names of all the products possible and describe their use really in concordance with accepted practice guidelines when possible. So my learning objectives today, I'm going to review several new medications, which is quite exciting for us for the treatment of lupus and lupus nephritis, and try and put them into their place in our treatment algorithms. So by the end of the session, I'm hoping that everyone can evaluate the recent lupus therapies' effectiveness and their studied target subpopulations, identify when to add these medications to the current treatment algorithm, and review future medications being studied in lupus and unmet needs for our lupus patients. So I have three different cases. I'm going to start with a case of new-onset lupus nephritis. I'm going to talk next about refractory lupus nephritis, and then more severe systemic disease. I'm going to touch a little bit on how we do assessments in our lupus clinics, probably not so much in general rheumatology, unfortunately, although it's in our Canadian guidelines, to use a SLEDAI or an SLE disease activity index, and we'll kind of go through those briefly. I'm going to look at our current treatment plans and then what's coming through the pipelines in the next 2 to 5 years. So my first case, and these are not meant to be diagnostic challenges. This is more about treatment than diagnosis. So 25-year-old Asian Canadian with a diagnosis of lupus 2 years ago, based on polyarthritis, cytopenias, and positive serology. She's had relatively mild disease, treated with NSAIDs and hydroxychloroquine or Plaquenil. And now we've seen her today. We have new onset proteinuria over 1 gram. We have hematuria with greater than 5 cells per high powered field. She has leukocytes lower than 3, as well as an increase in her double-stranded DNA antibody levels and low complement C3 and C4. So in the Canadian guidelines, we use something called the SLE disease activity index. This is the 2K version, but they're all very similar to each other. It's a single page, but I split it into 2, so hopefully you can read it. I'm going to see people squinting at the board. And everything is weighted, so the top point items are out of 8, and there's a whole group out of 4, 2, and then 1. The 8-point items are largely CNS disease. So unless you have a patient with CNS, they're probably not getting those. The exception would be, and I don't know if anyone can see my pointer, would be for the vasculitis. So that would probably be the most common 8-point item that I see in my lupus patients. But she has none of these. So we'll skip to the bottom half of the list. So carrying on with 4, she has hematuria, again, greater than 4 red blood cells per high powered field. And we've excluded other causes for that, particularly menstrual. She has proteinuria greater than 0.5 grams for 24 hours. She has low complements, she has increased double-stranded DNA, and she has leukopenia. So her total SLEDAI is 13. And you'll see in some of the studies that they use those SLEDAI indices. And so for rheumatology, when we go to apply to use the medications, we have to provide the SLEDAI score. So that's the incentive for learning and seeing what that's about. So she got a renal biopsy because she lives in BC and we do lots of biopsies here. So in her renal biopsy shows class 4 and class 5 mixed lupus nephritis, moderately active, but no chronicity. This is early in her disease, her first flare, and we've caught it relatively quickly. So in terms of treatment, you have 4 different options. You can start around high-dose mycophenolate, 1.5 grams BID, high-dose steroids, methylprednisolone, 1 gram IV daily times 3, and then stepping down to oral 60 milligrams per day and tapering. Option B is the same, except for the dose of mycophenolate is down to just 1 gram BID, and the methylprednisolone is dropped to 500 milligrams. Option C is using what we call the Lupus cyclophosphamide protocol, which is 500 milligrams IV every 2 weeks for 6 doses, then maintenance azathioprine plus the high-dose steroids. Or option D is also Lupus cyclophosphamide with maintenance mycophenolate plus the steroids. So I'll give you all a minute to think about what you might do. If there's nephrologists in the audience, this is bread and butter for them. And the most recent guidelines actually do come from nephrology. So the KDIGO 2021 lupus nephritis guideline is already out of date, and they acknowledge that even when they published it, but it isn't the most up-to-date published guidelines at the moment. So their recommendations for induction therapy for proliferative class 3 or class 4, they're treated the same, would be IV methylprednisolone, but a lower dose than what we used to use in the past, 0.25 to 0.5 grams per day for 3 days, followed by oral prednisone at 0.6 to 1 milligrams per kilogram ideal body weight. So if we think back to our patient as a young Asian female, good chance she's not 60 kilograms or she's just barely 60 kilograms. We might get away with a lower oral dose than 60 milligrams as well. And then we aim to taper that prednisone relatively quickly. So down to 7.5 milligrams by the end of 3 months, plus either IV cyclophosphamide in the Lupus protocol or oral mycophenolate, and they give you a range of 2 to 3 grams per day for 6 months. So going back to our answers, we could use most of those, though all of them actually probably had more steroids than she needed. In terms of maintenance, if you see response, then you're going to taper your prednisone down to less than 5 to 7.5 milligrams per day. Your first choice for maintenance is always mycophenolate mofetil, 1 to 2 grams per day, or mycophenolaic acid, which is more expensive and so used less frequently. But for individual indications, you can use azathioprine. If neither of those are tolerated, then tacrolimus targeting a trough of 4 to 6 nanograms per mil or cyclosporin A are also recommended. Nizorabin is a medication we don't have in Canada. So, I would say that most of the nephrologists here start with mycophenolate rather than the oral cyclophosphamide or IV cyclophosphamide rather, and they use mycophenolate for maintenance. The main individual indication for switching to azathioprine is if patients want to get pregnant, as mycophenolate is contraindicated, but azathioprine is considered safe in pregnancy. So unfortunately, the duration of therapy overall is not clear. Should be at least 36 months. And if patients are improving, allowing 18 to 24 months to achieve a complete renal response is considered reasonable. That's really hard when you're sitting in front of your patient and seeing a really slow improvement. But as long as you are seeing that improvement, it's okay to not change treatment. And they put explicitly in there that new medications were not included in those guidelines, and so they're expected to be updated shortly. So this is back to our patients. So we talked about the guidelines. The older EULAR, which is the European League Against Rheumatic Diseases, and the ACR, American College of Rheumatology guidelines, both use either mycophenolate or cyclophosphamide, similarly to the kidney guidelines. She chooses mycophenolate, which she doesn't tolerate particularly well, but I put a little word in here for adherence. So one of the things that we find in rheumatology is that our patients don't like taking their medications, and if they're starting to feel better, they frequently won't take them. So it's always a good idea to check for adherence as you make treatment changes. And so for her, she improved her proteinuria 3 months down to 1.5 grams per day. but then no further improvements, and she has ongoing mild hematuria. Her initial double-stranded DNA levels improved with the high-dose steroids, but they're still above her previous baseline. And so with that ongoing proteinuria and a bit of hematuria, she actually got a repeat renal biopsy. And I just mentioned there that I think there's some increased evidence showing that the urinalysis is not as good as we thought it would be. And a lot of patients can have a fairly benign urine and still active disease. So the number of repeat biopsies for kidney disease has actually increased over the last few years. So she had a repeat biopsy at 9 months, which showed persistent class 4 lupus nephritis. So now what would you do? This is when it starts getting harder. So as I said, the guidelines actually tell you, A, you could continue with high-dose mycophenolate as she's had a partial improvement. The other option is to switch. So B, switch to urolupus cyclophosphamide, and then back onto my maintenance mycophenolate as planned. But that would be old school. And so, of course, we have to talk about the new medications. So C is advoclosporin, D is adbelimumab, and E is obinutuzumab. So that's just the old guidelines from that I've mentioned before. So you can have mycophenolate plus steroids or cyclophosphamide. And then if they don't respond at 6 months, you switch to the other medication. But this is the first of those new treatments that we talked about. This is voclosporin. It comes from Aurinia Pharmaceuticals, which is based in Victoria, so a local success with a randomized double-blind placebo-controlled trial published back in 2021. Biopsies of class 3 and class 4, plus or minus class 5 lupus nephritis. They were given background therapy, so this was add-on to our usual treatments, background of 2 grams per day of mycophenolate, and they were targeting a complete renal response with a urine protein creatinine ratio of 0.5 milligrams or less, and stable renal function, no rescue medication, and prednisone less than 10 milligrams. And what they found, important for new medications, no safety signals. There were 6 deaths in the trial, which seems high, but only 1 in the voclosporin group and 5 in the placebo. None felt to be related to the study treatment. So calcineurin inhibitors, a little bit on this side, interfere right in the nucleus in terms of production of interleukin-2, and that's going to translate into a decrease in active inflammation in our patients. There's other studies looking at targeting other pathways to get to IL-2, and this is not specific to voclosporin. It's a similar mechanism of action for tacrolimus, which we do use more regularly, and for cyclosporin. I think I have it on the next slide. The important parts about voclosporin is that it's much safer. It has a broader spectrum of tolerable dosing, so you don't have to follow levels. It doesn't as much or as closely, and it's better tolerated. So in terms of this, they did a 52-week study with a 2-year extension on the end, looking at voclosporin addition to or placebo with that background of steroids and mycophenolate. Really rapid steroid taper, so that patients were down to 5 milligrams or so by week 6, which is much, much faster than the guidelines, which were aiming for 7.5 by 3 months. Definitely helps to improve toxicity of steroids if you can get them down. And this is your complete renal response in panel A, your partial renal response in panel B. And overall, it was a positive study with an improvement in complete renal response seen already by week 24 and maintained out through week 52. Much higher numbers if you accept a partial renal response, with a difference of 20% there. And I love these little summary slides of the study that they published. So this is the same data, just kind of summarized in a table, showing that there's an odds ratio of improvement with voclosporin over placebo of 2.65 at week 52 was 2.23 already at week 24. Similar serious adverse events in either group. So over at this side, 357 patients. 27 countries, though, to get that many. So variety of different background treatments. So that was voclosporin. Sadly, we probably won't ever see it in Canada because it's been priced for the American market at something like $100,000. And there's not convincing evidence that it's enough of an improvement over tacrolimus that we ever expect to have it covered here. So I just tend to lump all the calcineurin inhibitors together. This is belimumab, which is an old drug, but with a new indication. So it was initially approved for non-renal lupus back in 2011. Unfortunately, not covered in BC, except through private insurance. So we haven't seen a lot of use of it here, but widely used in other countries around the world. And this was their renal disease study that was published back in 2020. So a 2-year randomized controlled trial of belimumab and lupus nephritis. Similar number of patients to voclosporin with 448 patients, multi-center, multi-country. Same inclusion of class 3 or 4 with or without class 5. They needed to have sufficient renal function of greater than 30, and they received add-on therapy as with the voclosporin trial. So this was added to the standard of care. Because of the different countries enrolling, that standard was not prescribed. So voclosporin mandated it was mycophenolate. This did include a few patients on cyclophosphamide as well. And their primary endpoint was not until 104 weeks. So still looking for the urine protein creatinine ratio to be improved to 0.7, stable renal function, no rescue, and a complete renal response if it was less than 0.5, and the GFR no more than 10% below pre-flare. Was criticized for having very few Black patients included, and definitely more patients received mycophenolate than cyclophosphamide. But the responses were similar with regards to their response adding on the belimumab. So a little reminder here from basic immunology that the B cells require stimulation to proliferate through the BAFF pathway, through the BAFF receptor as well as the BCMA receptor, and the belimumab comes in as a blocker of this BAFF signaling, so they don't get these survival signals and you have death of the B cells. It doesn't actually deplete the B cells in the same way as rituximab or another B cell depleting molecule, but you do have significant improvement in the sort of overactive B cell population that we have in lupus. So this was their response. So we see that the primary efficacy response over time, definitely showing improved outcomes with adding belimumab versus placebo. Complete renal response has lower numbers, but a similar splitting out. And it probably does split out much earlier than their primary endpoint back here at that 24 to 34, 40 weeks mark. I'm not going to spend a huge amount on that because I don't think you can read it. So this is that summary graph showing that if we compare placebo to belimumab in terms of partial renal response, you go from 32 to 43%. In terms of complete renal response, you go from 20 to 30 with odds ratios of 1.6 and 1.7. So both medications are shown to be effective. There was actually a debate at the American Rheumatology meeting a couple of years ago as to which medication you should pick. And a lot of it comes down to whether or not there's disease outside of the kidneys, because the voclosporin is fairly specific to renal disease, whereas the belimumab obviously has the previous indication for more systemic symptoms. So if patients also have systemic disease, you probably would reach for belimumab. So, and then a quick word about obinutuzumab, because it is probably coming this way. It is another B cell depleting molecule like rituximab, but much stronger and much more effective. It's already being used in cancer patients, including in Canada. And so there is some access through hematology, though I don't think anyone's tried to use it for lupus patients yet. This was only a phase 2 that they presented, so 125 patients with class 3 or 4 lupus nephritis, similar protein, randomized again to add-on therapy with obinutuzumab or a placebo, and endpoints out at 104 weeks. The complete renal response rates were similar to the definitions in the voclosporin trial, but their endpoint was out at week 104. They had 5 deaths, including one in the obinutuzumab group with gastrointestinal perforation and 4 on placebo. They did have a fatal case of P&L in a patient assigned to placebo who also received cyclophosphamide rescue therapy. But this is probably related to the lupus as much as anything else. The reason I put it up here, even though it's phase 2 data, is because the improvements were much more impressive. So complete renal responses went from 20 to 40% as opposed to 20 to 30 with belimumab. Partial renal responses, similarly, we're seeing numbers up over 50. And the modified complete renal response is up at that rate as well. So given that early improvement and the differences that we're seeing, this drug is actually available for rheumatologists in the US, and they're already using for their patients with really severe disease. And I just thought I'd put this up here to show that it has an early and really impressive improvement in terms of normalizing C3, C4, decreasing the double-stranded DNA, and improving the GFR. So that's panel A. Panel B shows the level of depletion, and you can see out at week 52 that 94% of the patients who received obinutuzumab had depleted their B cells versus the placebo patients, where a few of them had no B cells, but very effective, very complete response, much better than we see with rituximab in lupus. So waking everyone up a little bit, same patient 6 years later, she responded to her urolupus cyclophosphamide and maintenance mycophenolate for 3 years, then was slowly tapered off. She's been off mycophenolate for a year, and unfortunately she's flared again. Again, she has proteinuria and hematuria. She has low C3 and C4, high double-stranded DNA, and the leukopenia, all of which we had at the first flare. But now she's also got anemia, arthritis, and new vasculitic skin lesions. So this is pointing out back on that SLEDAI that now she does have that high 8-point vasculitis point. She also has an extra 4 points for the arthritis. Hematuria, proteinuria, low complement double-stranded DNA, and leukopenia were all similar to before, but her total score is now 25, which is really high. The scale goes up to 108, but we never see patients up above sort of 30-ish. So this is an unwell young lady. She got a repeat kidney biopsy showing class 4 active disease, but she now has some chronicity because this is her second flare of disease. So now what are we going to do? We can repeat the urolupus cyclophosphamide, though everyone gets more nervous the more cyclophosphamide you give to people, because she's now 31 and she's thinking about children, and there's increased infertility with cyclophosphamide. We can increase her mycophenolate to induction dose and see if she responds. But we're a little worried because she didn't actually respond to that the first time through. So many patients run true to course for their own disease. While we have a huge variability across the spectrum for different patients, I would be a little worried about just using mycophenolate. Then the option C would be to add an additional immunosuppressive with either a calcineurin inhibitor, belimumab, rituximab, or obinutuzumab. And unfortunately in BC, that means what does she have for medication coverage? And then you could just use maintenance dose mycophenolate with the additional immunosuppressive just because you're worried about infection and other intolerances. And keeping in mind that that voclosporin study did just use 2 grams a day. So there's no clear answer. I mentioned once before, but I always bring it up, that adherence data is really poor for lupus patients. So if they're already on mycophenolate, make sure they really are taking it. In terms of medication availability, none of them are available through pharmacare yet. So you have to look at their drug coverage. extrarenal disease. We now have vasculitis and arthritis, so I would be a little worried about just using a calcineurin inhibitor, though truthfully, some of my patients respond in their arthritis to calcineurin inhibitors, so that might be past treatments that I said, you know, she didn't respond to mycophenolate the first time, I would be worried about using that by itself, and some patient preference, that whole pregnancy question comes in there. If possible, I would try add-on immunosuppression. If I could, I would either add belimumab or a calcineurin inhibitor for her. Always keeping in mind that these are young patients and we want to limit our steroid exposure and damage. All right, so case number 3. This is a 35-year-old with a 20-year history of lupus, based unfortunately on one of my sick young patients, including previous hospitalization for pulmonary hemorrhage. She's had 3 flares of lupus nephritis in the past, including an associated posterior reversible encephalopathic syndrome, or PRUS. She's recently been maintained on mycophenolate, a gram BID. She's never been able to get her prednisone below 10 milligrams daily, and she's on hydroxychloroquine regularly at 300 milligrams. On her routine lab work, she's got thrombocytopenia, her proteinuria has worsened, her double-stranded DNA has increased, her complements have dropped. And when she comes into clinic, because you see her blood work, she tells you about new pleuritic chest pain, arthritis, and worsened fatigue. So one more time through that SLEDAI, I cut off the top ones that didn't have 8 points with them. She's got 4 points for arthritis. She's got 4 points for proteinuria. She didn't have hematuria. She's got 2 points for that pleuritic chest pain, low complements, double-stranded DNA, and 1 point for leukopenia, with a total of 15. So she has a flare, and she was actually already on immunosuppression with mycophenolate and prednisone and hydroxychloroquine. So what to do now for this poor young lady? So renal biopsy, she's had multiple, she's had 3 flares in the past, so she's probably had 4 or 5 biopsies in the past, but you could repeat her renal biopsy so you really know what you're treating. You could just pulse her with prednisone and taper and just see if you can settle this down without having to change our underlying immunosuppressive therapy. You could add belimumab, because she is fortunate enough to have a good drug plan. You could add rituximab, and we actually still use rituximab even though the clinical trials were negative. It definitely works for some patients, and access is actually easier despite the negative trials than for the newer medications. Particularly, and I put that up there, if they have joint disease, because we can access it through our rheumatoid arthritis program. Or and this is what I wanted to bring up, was adding an anifrolumab, which is another new medication that we have. So it is a type 1 interferon antibody. It blocks the common receptor subunit used by all type 1 interferon subtypes. It has had positive or mixed data. So the phase 2 trial was positive. The first phase 3 trial was actually not, it was negative. And that was based on the SLEDAI that we've been using and their improvement. But they changed the endpoint in their second phase 3 trial to use a more sensitive response criteria called the BILAG for a BICLA response. And that trial was positive. Everyone was a little bit worried when they took it to FDA, but FDA approved it, and Health Canada subsequently approved it as well, because there's good science in terms of just showing that sensitivity to response is really important. If you look back on this SLEDAI, if you have arthritis, you have to go from more than 2 joints to none to get off those points. So you can go from 30 to 20 and it gives you no improvement at all. Whereas the BILAG response will allow more partial improvements. So I briefly am going to go through the trials, but similar to the last improvement, that they have the SLEDAI score of greater than 6. They excluded some non-specific items like fever and headache. The clinical SLEDAI, which does not include labs, had to be 4, so you couldn't just get all your points for the lab work. A BILAG, I'm not going to go through in details, but and category A is severe disease, B is moderate, C is mild, D is none, and E is never had any. A physician global greater than 1, they had to be serologically positive, so ANA, double-stranded DNA Smith positive, one of the, not all three, and that they had to be on a baseline treatment with prednisone, plaquenil, azathioprine, nizorabine, mycophenolate, or methotrexate. And they excluded patients with severe renal or CNS lupus. And as with other trials, severe really does mean quite severe disease. There's patients with mild, even moderate lupus nephritis that squeak into these trials. I won't go through the panel because it's too small. So this was their endpoints. So they looked for the response rate for placebo versus the anifrolumab group, and they went from a 31.5% to 47.8% improvement, which was statistically positive. And then they broke it down. So we did see some improvement in terms of steroid sparing, which is really important in our patients, going from 30 to 50%. They did have a reduction in their CLASI, which is their skin score. So this drug has been shown to be remarkably effective for skin lupus, and probably one of the really important treatment options for patients with severe skin disease. So an improvement of 24 points there. The improvement in the joint disease was not nearly as impressive, in fact, not statistically important. And then they did have an improvement in their flare rate as well. So this is the summary slide for that. So again, similar size trials. These are big for rheumatology, tiny for many other specialties. 362 patients with moderate to severely active lupus treated with anifrolumab every 4 weeks IV versus placebo, and the response at 52 weeks was 47.8 versus 31. So more patients had a response than in placebo, and they didn't have a lot of significant side effects with this. So in our patient, we now have repeat renal biopsy confirming class 4 lupus nephritis. As we said, she's had 3 episodes in the past. So now she's got 8 out of 16 sclerosed glomeruli, despite only being 35 years old. In terms of what we're going to recommend next, I'm going to argue some of that. The biopsy didn't change anything. You're going to add belimumab because it works for lupus nephritis as well. Or you're going to add rituximab if you don't have access, probably. Or now we know she has active lupus nephritis. Some people would reach for a more kidney-specific medication like a calcineurin inhibitor, or she just has severe disease and we're going to get the strongest treatment we have, which is obinutuzumab. This was the little bit of the data. I don't think I'll go through it in detail about there is some data for anifrolumab in lupus nephritis, so you wouldn't be totally wrong for our patient, but it's phase 2 and it only worked at a higher dose because the active renal disease decreased the PK exposure so that the patients needed to have a increased dosing regimen to reach their primary endpoint. So there is a phase 3 trial going on, but you wouldn't be using it off-label if you wanted to give it to a patient with active renal disease. So unfortunately, in 2023 in BC, publicly funded medication access is limited to mycophenolate or myfortic, tacrolimus or cyclosporin as our calcineurin inhibitors or cyclophosphamide. If they have arthritis, and sometimes if you beg and plead, you can get access to rituximab. And if they have really good insurance coverage, they may also be eligible for belimumab or anifrolumab. And that's because Health Canada approved those 2 medications a couple of years ago. But in December, we had really good news that we had CADTH positive reviews for both of those medications. So we're really hoping that in the next 6 months, maybe, that both anifrolumab and belimumab for lupus nephritis will be accessible through pharmacare, and we'll see much more uptake for those. In the US, they're using a lot of voclosporin, and obinutuzumab is available as well. And so if you read anything about a patient in the US, that they may be using those medications. What else is coming? Lots. So in terms of case series, and we're going to touch briefly on the CAR T cells because it made a lot of buzz in the New England. anti-CD38 or a plasma cell depletion medication has also had really good case series data. Phase 2 positive trial for deucravacitinib, which is also being studied in ankylosing spondylitis and spondyloarthropathies, is a TYK2 inhibitor. So we're using JAK inhibitors. This is similar in terms of a small molecule. We're very exciting. Patients really love it if you can give them an oral medication instead of something IV, and it's rapid onset, rapid off. So we're excited about that. And then phase 2 negative, but for mixed reasons, they're all going on to phase 3 for multiple other medications. And so with rheumatoid arthritis, we've had many biologics approved and lots more coming. Still, lupus is much slower to get off the mark, but it seems like we're starting to see some progress and hopefully more over the next few years. I will skip over that. So I thought I'd touch briefly on the CAR T cells in terms of a potential new therapy, just because it's caused a lot of buzz amongst the rheumatology community, even though it is just at the case series level or in early plans of randomized controlled trials. So chimeric antigen receptor or CAR modified T cells are genetically engineered to recognize CD19 or other B cell antigens, and they're used for relapsed or refractory B cell cancers. This was a letter published in 2021 for the use of those CAR T modified T cells to treat a woman with lupus. So she was 21 years old. She had nephrotic syndrome with class 3A lupus nephritis, but she also had quite severe systemic disease with pericarditis, pleurisy, rash, arthritis, as well as Lehmann-Sachs endocarditis. She has previously failed hydroxychloroquine, high-dose steroids, cyclophosphamide, mycophenolate, tacrolimus, belimumab, and rituximab. So she obviously was in the US. And so she was consented and CAR T cells were produced targeting the CD19 surface receptor. She was conditioned with lymphodepletion, sorry, the spelling mistake, with fludarabine and cyclophosphamide, and then given a CAR T cell infusion. And the top panel in panel A shows the analysis of the circulating cells. I think clinically not quite as important for us. So I've squished it down so that we can see some of the other things. Panel B shows the double-stranded DNA antibodies just plummeting, her C3 normalizing, her C4 normalizing, and the, even I can't read the bottom one, proteinuria depleting down at the bottom. And in panel C, this is her SLEDAI score. So they put it into different colors based on the points that she had initially, including, new rash was light purple, her pleurisy was dark purple. You can see that those were present and then really quickly disappeared. The yellow is the anti-double-strand DNA antibodies, and they were the slowest to finally go negative out by week 42. In green is her complement levels. Again, they disappear by week 23, or normalized rather. Her physician's global also dropped off down to, looks like 0 by week 30. The proteinuria disappeared by week 30, and in orange is her arthritis, and it resolved really quickly as well. And so she's had a really remarkable improvement for somebody who was resistant to all of those 7 or 8 different treatments within about 6 months of treatment. And then this is the other data that we had presented at EULAR. This is a group of patients. So they had 5 patients, including 4 women, young, only aged 18 to 24, with disease duration of around 4 years on average. Their SLEDAI scores were 8 to 16. So I just gave you examples of 15s to 30. These were all patients in that similar category, all with lupus nephritis. And so they had previously failed multiple treatments. So all 5 had pulse corticosteroids, all 5 were on hydroxychloroquine, all 5 had mycophenolate, all 5 had belimumab. So this shows us that this, despite not being used locally, it is being used around the world. Cyclophosphamide in 3 of them, and azathioprine in the 2, and 1 patient had also had rituximab. Again, they created the anti-CD19 CAR T cells and lymphodepleted the patients with fludarabine and cyclophosphamide, so very similar to the first patient. And a very similar response, deep depletion of the B cells, reappearing after a mean of 110 days, which were in a naive state and non-class switched. So important, they've kind of reset the B cells with this treatment. They were in this really rigorous DORIS remission with a SLEDAI of 0 after 3 months, extending in their follow-up out to 17 months. They did have a very mild cytokine release syndrome, which is a side effect they see quite frequently with the cancer patients, with fever in 3 patients, but it was brief. 1 patient did receive a dose of tocilizumab for that. Their CRP and IL-6 levels increased, but not with any clinical symptoms in 4 out of the 5 patients. And somewhat unbelievably, none of them had any infections. And so with that handful of cases, there's much excitement about the potential of treating our patients with really severe refractory disease. So you saw that age group was 18 to 24, because we know in our lupus patients, those with pediatric onset or really young adult onset tend to have more aggressive disease with multiple flares over time, high risk for going on to dialysis and kidney transplants and other complications from their steroid use. So very appealing. I think the price tag for CAR T therapy is somewhere in the order of $100,000. So not for everybody. But there's definitely some clinical trials going on. Also looking at different targets. So all of these patients looked at just using the CD19 cells. So similar to rituximab and obinutuzumab, which target the CD20, these ones are targeting a little bit more immature B cells as well. But there is definitely some science going forward looking at other specific targets for patients. So I think I'm going to end a little bit early, but so we talked about several new medications for the treatment of lupus and lupus nephritis. We talked about anifrolumab, which is going to be called Safnello for non-renal lupus, which is well tolerated and improved overall disease. It does have some increased herpes zoster, so we pre-vaccinate everybody before they get anifrolumab. We talked about belimumab for both non-renal and renal lupus. Well tolerated. Many of the patients have been on it for years. I have a patient who was in the phase 2 trial who continues on it. Very well tolerated medication, not any specific side effects for her. Improved renal response rate versus standard of care for both class 3 and 4 lupus nephritis, in addition to the already studied non-renal improvements. We talked about voclosporin for renal lupus, and I put in brackets or other calcineurin inhibitors, which I think we're seeing already that there's many more patients receiving tacrolimus for their lupus nephritis in BC, show an improved renal response rate, and they're also generally well tolerated. What's not known is when to add these medications to the current treatment algorithm. Generally early, if not responding to standard of care, but the trials were within months of biopsy. So we have a little bit of time to see if mycophenolate would work on its own. There's many future medications and treatments that I glossed over and didn't go through in details, but I think that there's a lot of potential in terms of new targets and new treatments. There's many more unmet needs for our lupus patients, and due to poor tolerance or poor response, we don't know when to taper them off immunosuppression. We don't always know the correct dose and duration for our steroids, and they all have steroid toxicity. So there's lots more room. I didn't include it here because I don't have enough expertise to talk about it, but there's a lot of work being done on biomarkers. So urinary biomarkers are very appealing to avoid all the renal biopsies in our patients. But I think even more exciting is a lot of work being done with RNA profiling and putting those into big data and trying to predict which patients will flare, what their flares will mean, and what their treatment responses will be. There's already some open access AI programs that if you can get the data from your patients, you can plug it in there and get whatever it will predict for you, and those are only going to improve over time. So I think with that, I am finished. I'm happy to talk more if anyone has more things they want to talk about in terms of other treatments. Happy to answer questions. I don't think I can see the Zoom chat anywhere. Can you see it? No.
We'll just ask. Is there anybody online that has any questions for Dr. Reynolds?
Can you talk?
If not, what about questions from the audience?
Was there anything on the chat? You were on there.
So
Nothing.
I have a
Perfect.
question.
Yeah.
I mean, what you've shown us a variety of different medications, all targeting different parts of the cytokine and immunologic system. You've suggested by the use of the medications that different components of lupus seem to respond to different drugs. The arthritis, the kidney, the heart. So can you educate us about new thoughts about the antigen for lupus and why different parts of the immune system are activated to affect different organs so that we can decide? Because really this is a potpourri. Try this.
At this point,
Yes.
We
So-
don't have any good predictors as to who is going to respond. There isn't one gene or one antigen. There's going to be multiple, and there's better data coming about clustering the patients. So we lump them all together and call them lupus, but they're probably multiple different types of lupus. And if you can cluster them together, you'd be better able to predict a response. A little bit with rituximab, we know that we're targeting B cells. So the patients who have a lot of high levels of autoantibodies and other signals of B cell activity tend to be the ones that we would favor using that therapy for. But as with any of these, I wouldn't hold it back from a patient that didn't have those things, because I will see responses in those patients as well. With the anifrolumab data, all patients got an interferon level. And we know from collecting the samples from the patients that 80 to 90% of patients will have markers showing high interferon activation when their disease is active. But interestingly, they also saw responses to anifrolumab even in the patients that didn't have those high signals. So I don't think we know yet. I think that's where those genetic profiling applications are really going to be helpful in breaking it down and showing us who to target with a specific treatment. I glossed over, and nobody has raised it yet, what we've now kind of broken down into type 2 signals. So a lot of the lupus patients, their main complaints, their main symptoms are things that we don't even measure immune activity for: the fatigue, the brain fog, the overall malaise, that mild fevers that they all complain about. They may have completely normal serology and normal CRPs. They don't correlate with those symptoms at all. Interestingly, some of the belimumab and anifrolumab data shows those symptoms improve with immunosuppression. So we're just not able to measure it. It is part of the disease. But I think trying to tease out those patients and what they're going to respond to is really important, because I can throw cyclophosphamide at them and it doesn't make them any better. Yeah.
Well, just to add the perspective that, when I started practice, prednisone was the hammer. And so it's been dissected to smaller and smaller hammers, but we're using multiple hammers at times in the wrong area and maybe you're right, maybe lupus is the wrong name for this disease combination. Any other comments or questions, since I seem to be having a conversation? Yes.
Yeah, so with the newer medications that are not covered by MSP, but you might get coverage through private health insurance. So moving from clinical trial to real world, so what are we looking at? So for example, in your own practice, how many patients have you experienced now with these newer medications, and have you noticed a change in your practice as far as how patients are responding who previously didn't have these medications?
So my experience is limited to belimumab. I haven't had access to any of the other ones yet. But what I've been really impressed with belimumab is how well tolerated it is. It is not a big hammer. It is not going to cure their disease, but overall patients tolerate it really well and they improve significantly. And these are patients generally who you've tried everything else with. So if I can even get them on 5 milligrams less a day of prednisone, I'm super happy. Yes, prednisone works. And I always tell patients and trainees that, if you have a symptom or something and it doesn't get better with prednisone, you should question whether it's part of this disease. But at the same time, I also teach P for poison. This is #1 drug that is going to cause all of the harm for all of these patients. We have a damage index, and 90% of the things that show up on that are all from the prednisone, not from the disease. So we recognize it works, but we try desperately not to use it. And if I can use another immunosuppressive medication instead, I will reach for that every time. Unfortunately, I in the last few years, I increasingly feel my hands are tied and I watch other parts of the world reaching for them earlier and having better responses. And then I do.
And what is the cost of that?
So belimumab, I think, and it's hard to find that, is roughly $30,000 a year. And so they priced it initially to compete with rituximab, but now rituximab has biosimilars, so it's way down on the price. That's why I said I can get rituximab, because the pharmacare would much rather pay for that than they would the other options. But belimumab is in that price range. I think Safnello is going to be priced similarly because it has the same kind of efficacy, the same target population. They have been a little bit more proactive in terms of getting access through through the insurance plans. So even if they have insurance in BC, most of them say no to belimumab, but the Safnello team, I don't know, selling people and cruises, I don't know how they're doing it, but they're getting more access through most of the programs for Safnello. So I think we'll start to see that increase. I went to a talk by a rheumatologist in Texas who already has 100 patients on Safnello, and he is, as the months go by, using it sooner, using it more frequently, using it for more indications, because again, it is so well tolerated. Patients do really, really well on it, and he can get prednisone doses down. So I think both of those are, for non-renal disease, are going to be really, really important. I think we are using tacrolimus way earlier in BC. If you looked over the last 5 years, lots more, adding it by that 3-6 month mark if you're not seeing significant improvement, particularly for renal disease. But I now use mycophenolate for non-renal. I'm using tacrolimus for non-renal disease as well, with good response. But back to Barry's point, if I have a patient with arthritis, I put them on methotrexate. I don't put them on azathioprine. I don't think mycophenolate works very well. I'm reaching for methotrexate. So I am on multiple medications for multiple manifestations. Sure. But in some ways, then I can keep toxicity down for lowering the dose for those things. And
maybe one further question: using the SLE-DAI, is that a frequent? Are rheumatologists using that, or just certain rheumatologists?
So lupus clinics all do. If you want to access belimumab, most of the insurance companies request you to fill in a SLE.
Okay.
So yes. Okay. And anifrolumab will be the same, because that's what the indication was for the trial. They had to have a SLE score. Yeah. So when they're going to go pay for it, the patients have to have a SLE score that meets a certain bar. It's not an ideal thing, but it is a single page. It looks confusing up here, but it's 2 seconds in the office to fill it in.
Any other comments or questions? If not, thank you very much for a great talk. Thanks.
Thank you.
That's really exciting.
Yeah, lots more.
But